Hello, everyone. I'm your moderator for today at Ofori. I'm an assistant professor at Arizona State University, the director of the Pathomechanics and Neuroimaging Laboratory, where my research focuses on brain and motor biomarkers of neurodegenerative disease, including Parkinson's disease. My work integrates advanced neuroimaging, digital motor assessment, and cognitive motor testing to improve early detection and intervention strategies for neurodegenerative disorders. I'd like to thank you all for spending your time to join us for our Health Talk webinar brought to you by the College of Health Solutions at the Arizona State University. Our college works to address challenges facing people and communities to stay healthy, improve their health, and manage chronic disease. These health talks are one way we serve the community with timely and relevant educational information that provides continuing education credit at no cost. Before we begin, we have a few quick housekeeping items. First, this session is being recorded and will be posted on our website, asuhealthtalks.com. After the main presentation, we'll have about approximately 20 minutes for Q&A. Please submit your questions using the Zoom Q&A feature and not the chat box. Regardless of whether you have or not requested CEUs, please register your attendance today using the self-check-in list posted in the chat, so we have an accurate record of who's attended today's webinar. And finally, of those of you who are attending live, we'll have a brief survey asking for your input about today's webinar. If you're requesting continuing education credits, this must be completed in order to receive your credit. If you did not apply for CEUs, we would still appreciate your feedback to improve our series. And as this is posted in the chat as well. I am so excited to introduce today's speakers, Drs. Daniel Peterson and Dr. Shyamal Mehta. Dan Peterson is an associate professor at Arizona State University College of Health Solutions. His work focuses on understanding the interaction between balance, falls, and cognition in people with neurological populations such as Parkinson's disease and multiple sclerosis. In particular, he's interested in how rehabilitation can improve gait and postural control using principles of motor learning. Dr. Shyamal Mehta is a neurologist at Mayo Clinic in Scottsdale, Arizona, specializing in movement disorders. His clinic focuses on includes treating patients with Parkinson's disease, tremors, and dystonia. He's also the co-director of the Deep Brain Stimulation Program at Mayo Clinic, Arizona. He has active funded research program and collaborates with colleagues at ASU, including myself and Dr. Peterson. Dr. Mehta works to discern each patient's unique expectations of living with chronic disease, help patients understand their diseases, and empower them to become partners in managing their health. We are so very fortunate to have these experts with us today as we explore movement balance and safety, falls in older adults with Parkinson's disease. Today, we explore the critical connection between Parkinson's disease and falls in older adults. We will examine 1, common gait and balance deficits in people with Parkinson's disease, 2, how these challenges increase fall risk and affect quality of life, and 3, the clinical strategies most often used to improve function and safety. To start off today's group presentation, we will welcome Dr. Peterson.
So thanks again very much, Ed, for the introduction, and thank you all for the invitation to come and chat today. This is a topic that is near and dear to my heart, and also I wanted to say I really appreciate the opportunity to present with Dr. Mehta as well. He's been a longtime friend and colleague and collaborator, and I'm excited to continue to work with him moving forward. So as Ed mentioned, so this talk will be kind of 2 parts. The first part here that I'll discuss, we'll discuss some of the mobility deficits that are typical in people with Parkinson's disease, and I'll also talk a little bit about some of the neural underpinnings. That is, which parts of the brain might be changing in people with Parkinson's disease that contributes to those balance deficits. And then I'll turn it over to Dr. Mehta, and he'll discuss kind of some of the approaches to treat some of the mobility deficits, difficult as that is, in people with Parkinson's disease. And I have no relevant disclosures. Okay, so I just want to kind of introduce the topic here and underscore the importance of falls and mobility in adults in general, and particularly in people with Parkinson's disease. Falls, as you may be aware, are extremely common. They occur in half to two-thirds of the individuals with Parkinson's disease. They're extremely costly. We're over $62,000 per fall, and in some cases over $32,000 in direct costs per fall per person over the course of each year. And then, as you maybe know, they're extremely impactful. So they contribute to a whole host of negative outcomes. Some of those are physical injuries. Obviously, that results in hospitalization, commonly in some cases mortality. And there's also, we won't discuss it much today, but there's a lot of kind of psychological injuries, so to speak. There's things like fear of falling, reduced participation, reduced physical activity that can occur before and after a loss of balance or a fall that can really cause a negative cycle of fear of falling and then removal of participation in one's community and kind of reduced health outcomes. So they're relevant to kind of understand what the causes of falls are, what the characteristics, like that is what balance deficits might occur, and then ultimately what some treatment options are to ultimately reduce the impact of falls in older adults in general, and then again specifically in people with Parkinson's disease. So one of the things I want to talk about first is, again, kind of what's happening in the brain as we move and walk, and how that is influenced by Parkinson's disease in general. So there's been some work over the last maybe 15 or 20 years that first actually started in animal work way back, and then has been moved into humans over the last, again, like maybe 15, 20 years to look at which parts of the brain are likely most active as we move and walk. And there's a host of brain regions that move together as this so-called locomotor network. So there's areas up in the cortex, including the motor cortex and premotor cortices, areas down in the basal ganglia, the striatum, globus pallidus. There's areas in the brainstem, such as the mesencephalic locomotor regions. These specific acronyms aren't totally relevant or are totally important to keep track of, but there are brainstem regions, and there's also these cerebellar locomotor regions. And all of these together facilitate and contribute to effective locomotion. If we look at some of the neuropathology that occurs in Parkinson's disease, the basic neuropathology is the accumulation of different proteins called alpha-synuclein. And what we see is that alpha-synuclein deposition and aggregation early in Parkinson's disease, and kind of the stage 1 and stage 2 early stage Parkinson's disease, can start down in the brainstem. And then, as you can kind of see by this figure, as Parkinson's progresses, the aggregation accumulation of this protein that can cause some of the pathological changes in Parkinson's disease kind of moves through the brain up towards the neocortex. And it actually, as kind of you can kind of look at the schematics across both figures, it moves through many of the parts of the brain relevant for locomotion. And that is, it's then no surprise that, as we'll see in a few minutes, there are a lot of different aspects of gait and balance and mobility in general that are impacted in Parkinson's disease because, again, many of the locomotor network structures are influenced specifically in Parkinson's disease. And it's worth noting that it's not only locomotor network structures that are influenced in Parkinson's disease. There are a number of non-motor deficits and non-motor changes that happen in Parkinson's disease. Those relate to attention and cognition. Those can influence autonomic function, reward systems, and so on. So it's not only motor function, but of course, for the purposes of this topic in this talk today, we'll focus specifically on some of those motor and mobility functions. So I want to talk now a little bit about so given the fact that we have these changes in locomotor structures in people with Parkinson's disease. We'll talk in more detail about that in just a moment. I want to talk a little bit about what gait looks like in people with Parkinson's disease. What are the specific behaviors that are changed? I know Dr. Mehta will discuss this a bit more in his talk as well, but I want to do this in two parts. So the right side here, you can see this is called a radar plot, and all the nuances of this are not necessary to consume, but what radar plots like this show are that there's different domains of balance. So for example, there is a pace domain, things like the velocity of steps and the length of steps. And there are variability domains, so things like the variability of the timing of steps and the length of the steps. There's a rhythm domain to gait, things like the stance time and the step time. There's asymmetry, so asymmetry across stepping on the left side and the right side. And then there's postural control domain, so that is the width of the step and the double support. And gait in general is this multifactorial thing that can be broken up into these kind of domains. And many, if not all of these domains are impacted in people with Parkinson's disease. So the radar plot kind of shows that, but I'll talk about some of the specifics. So one way in which, domain of gait in which Parkinson's disease affects gait is the size of movement. So it's very typical to see in people with Parkinson's disease, so-called hypokinesia. So that is a small or a reduction in size of the movements that happens with the steps, arm swings, etc. We also, in some cases, not always, but sometimes see a bradykinesia, so a slowing of movements, particularly the upper extremity. And we see rigidity, so axial rigidity, so across kind of the midsection of the body in particular, but also it can happen in the extremities, kind of stiffening of those limbs that can result in smaller movements. We also sometimes see, as kind of reflected in our radar plot on the right, we see variability and asymmetry in Parkinson's disease. So variability in that continuous steps are more variable in a person with Parkinson's disease than they would be in a neurotypical adult without Parkinson's disease, let's say of the same age. And we also see a pretty large degree of asymmetry where, let's say, the steps on the left side of the body, the steps from the left foot, are smaller than that of the right, and vice versa. And that is due to a lot of things. One can be due to the fact that Parkinson's disease it can be often present in an asymmetric way, where it affects one side of the body earlier and more severely than the other. And then we see a lot of so-called postural instability. So this is, to some degree, discrete from the size and the variability of movement. But for example, as the person is walking, their center of mass or their trunk is moving much more. They're having trouble controlling where their center of mass is going. They have altered coupling of posture and locomotion. So standing and stepping, coupling those together can be tricky. They have difficulty, so-called, with reactive postural responses. So those are the movements that a person takes after they've lost their balance. So if someone bumps into you and you have to take a quick step to catch yourself, those movements, are also often just disrupted in Parkinson's disease. We see a lot of difficulty specifically in turning. So turning kind of brings all of this together. It requires effective control of your trunk. It requires effective stepping patterns, and all of that together results in poor turning. And then in some cases, as people kind of progress through Parkinson's disease, they'll often exhibit this symptom called freezing of gait, which we'll see some videos of this in just a moment. But basically, it has to do with, or the definition of this is an inability to take effective steps despite an intention to do so. So people would like to take a step, but it feels like their feet are glued to the ground, is what they'll say. So they're unable to take those effective steps and facilitate forward progress. So with that as kind of the background of some of the broad symptoms, I want to show you a couple of videos that illustrate some of these symptoms. So on the left here, you can see first, this is an individual with Parkinson's disease. You can see a little bit of the standard tremor on the left side. But as this person starts walking, you can see the small and asymmetric steps. You see here some instability, particularly during turning. Again, small, asymmetric, and somewhat variable steps here. And again, on turning, a little bit of instability. One of the things, we'll see this in this video and the next, but whenever the person has, let's say, parallel lines that don't give any visual cues about how large steps should be, you see those smaller and unstable steps. However, as you can see here, when there are visual cues on the ground, places that they need to step to, the gait can become larger, less hypometric, and generally more effective. So this probably what's happening here is by utilizing these visual cues, the person with Parkinson's is able to kind of circumvent some of the disrupted parts of the brain. This video on the right, this is actually posted via the Lancet online. This is really nice too, because it shows a lot of different components of gait, including freezing. So first of all, here again, this person has pretty severe asymmetry of steps. This, by the way, is when this person is walking when they're not taking their Parkinsonian medication, that is some form of dopamine replacement or levodopa. So off medication, you see pretty severe asymmetry of steps. pretty severe turning difficulties. And by the way, this would be characterized as a freezing event, whereby the person is trying to take a step, they're trying to initiate that step, but they're unable to. Again, oftentimes, if you were to ask these people what it feels like they'll say it feels like their feet are glued to the ground. After the turning event is over, they're able to facilitate steps, albeit a little bit less effective. Another component of freezing, or another aspect of freezing, is that it often happens more frequently when people are moving through a change in surface, or through a doorway, through an elevator doorway, et cetera. So you can see that occurring here. There's the freezing event that's happening. Freezing is also very common during turning. So this person, as they're trying to make in this case, a 180-degree turn, you see these freezing of gait events where there's a little bit of trembling of the feet. As an aside, I mentioned some of the non-motor components of mobility and Parkinson's disease. It turns out symptoms like this, like freezing, are also much more common whenever the person feels a time pressure, when they feel if they're agitated, if there's if they're distracted in any way. Here's another example of visual cueing improving stepping. So first of all, certainly no freezing, and actually much larger and effective steps. This is another example of cueing. In this case, it's not visual, but auditory. So in this case, the instructor here, the clinician, is holding is playing a tone. Beep, 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 beep. And when the individual with Parkinson's can hear that beat, that's then an auditory tone that facilitates gait. Here's a person walking when they're on their levodopa, on their Parkinson's medication. So you can see there's still a little bit of difficulty and still instability in turning, but the gait in general is much better. And I think this is a really important, and here the gait coming through the doorway is much more effective. But I think this is important in general because it demonstrates that while levodopa, so Parkinson's medication, does improve the quality of gait in people with Parkinson's disease, it doesn't fully alleviate these symptoms. I know Dr. Mehta will discuss that a bit as more. Okay. The final kind of component of my portion of the talk that I want to talk about is kind of bringing these two pieces together. So we talked a little bit about the neurophysiology of locomotion in general, and then we talked a little bit about the symptoms, the specific gait symptoms of Parkinson's disease. And now I want to bring them together to talk about how these different parts of the brain are specifically contributing to, or thought to specifically contribute to, different aspects of gait and gait dysfunction in Parkinson's disease. And I know this is kind of a busy schematic, but I'm going to kind of walk through different pieces of it one by one. So first of all, when we talk about the hypokinesia, the small size of steps in Parkinson's disease, it's thought that it comes primarily from the basal ganglia, the structure down in the deep part of the brain, being overactive. So the basal ganglia has these inhibitory projections to a number of different parts of the brain, including the cortex and the brainstem. And it's thought that the overactive inhibition from the brainstem is probably contributing to the smaller size of steps in Parkinson's disease, which, by the way, is probably why when you take levodopa, which puts some of the dopamine back into our system and it partially alleviates this over inhibition from the basal ganglia, steps get a little bit bigger. There's also some suggestion that the cerebellum there may be increased activation of the cerebellum in people with Parkinson's disease during locomotion, which could be, and it's not fully resolved, but it could be kind of a compensatory metric to compensate for some of the deficits of the basal ganglia. There's also a finding that in people with Parkinson's disease, in addition to, in some cases, feeling like their feet are glued to the ground, oftentimes when you ask people with Parkinson's disease, they'll say that they have to think about walking, whereas for most neurotypical adults, old and young, walking is a fairly automatic task. But again, with Parkinson's, they really have to think about it. They have to think about taking those steps and think about taking a step that's the correct size or whatever. And what that illustrates is a reduction in the automatic control of gait. And whenever we have a reduction in the automatic control of gait, the ability to facilitate gait in an automatic way, it becomes, by definition, more volitional. People have to think about those movements more to a larger degree. And when one has to think about gait, for example, to a more volitional degree, that results in a number of different things. It results in more asymmetric and more variable gait. typically, and it also results in a larger amount of what we call dual task interference. So, for example, if you're walking in a very automatic way, you're much more able to attend to other things, right? So if you're walking and the phone rings and you pick up the phone, if the gait is automatic, then you can talk on the phone effectively without any kind of interference between those tasks. But if the gait is very volitional in nature, you're thinking about gait, then when you pick up the phone, there's a lot of interference between those tasks. So either your gait will become much worse, or your attention to that phone call will become much worse, or both. So that increased in interference between the tasks can be very problematic, and it can increase the likelihood of a fall. Finally, I'd mentioned this before, but there's a fair amount of degeneration in the brainstem in people with Parkinson's disease, in some of those mesencephalic locomotor regions, anyway, reticular formation, et cetera. And that degeneration in the brainstem region probably also contributes specifically to some of the postural instability that can occur in people with Parkinson's disease. And really what that looks like is, some of these brainstem regions, particularly the pedunculopontine nucleus, can contribute to cholinergic function. So now later on in the disease, after there's some dopaminergic dysfunction and cholinergic dysfunction, this kind of double hit probably is what results in the more severe instability and fall risk that can happen later in Parkinson's disease. So just to kind of sum up here, we talked about a number of different things. We talked about some of the gait dysfunction that is typical in Parkinson's disease, things like hypokinesia, freezing of gait, instability, et cetera. And then we talked a little bit about the neurophysiology that can lead to those behavioral gait-related changes, right? So we talked about changes in the basal ganglia activity resulting in hypokinesia. We talked about degeneration of the brainstem locomotor regions that can lead to instability and freezing. Some of the cortical and cognitive changes that results in more volitional and less automatic aspects of gait that can result in poor attentional control, poor dual tasking, more variable gait. And then also we mentioned the hypothesis there might be an over-reliance on the cerebellum, which, by the way, can also be impacted in Parkinson's disease, resulting in ultimately an increased risk of falls. So I'll stop there, and I will unshare my screen, and I believe Dr. Mehta will pick up with his portion of the presentation.
Thank you, Dan. That was very insightful information. And now we'll hear from Dr. Shyamal Mehta.
Thank you, Dr. Peterson and Dr. Ofori. So I hope you can see my screen. So first off, I want to thank the organizers for inviting me for this presentation, and also my friend and colleague, Dr. Peterson, for years of collaboration and the good work that we've done together. So in the interest of time, so I'm going to talk about, again, gait disturbances in mid and advanced stage Parkinson's disease. I'm just trying to advance my slides. Yeah, I'm going to just try to focus the talk a little bit from a clinical perspective and talk about some of the treatments. I will skip through some of the slides that talk about the pathophysiology or other issues, as Dr. Peterson has very elegantly covered those. So as also Dr. Peterson mentioned, that gait problems in PD is a huge issue. As a clinician who sees patients all day long, it is a huge unmet need. And we predominantly see this problem be very significant and lead to falls and impair the quality of life, especially as the patient advance in their Parkinson's disease. So it's usually Hone and Yard stage 3 to 5. That's when we see this problem. It is a huge contributor to disability, impairment in quality of life. Falling, as you can all probably imagine, can lead to fractures, hospitalizations, and it's one of the single most important factor and the largest contributor to institutionalization. So where patients unfortunately would have to leave their home and be moved into a nursing home or thereof. Um, so Dr. Peterson again also talked about freezing. Okay, this is, I'm not going to go over everything, but it's where, as he described, the patients will tell you that their feet get stuck to the ground. It can occur in different stages of gait, like when they first stand up to begin walking. So during gait initiation, turning through narrow spaces. So when we see that often in the clinic, where if there are a couple of family members in the room and us, and then the patient gets up to start walking, it will, because of the tight narrow spaces, it can bring on freezing of gait. Obviously, going through doorways is a big issue, as that's when the freezing occurs. And also, even in open spaces, when there is a change in the pattern. So if they're going from, say, a carpeted area to a um, tiled floor, they can freeze because of that change in the pattern. Um, and as you can imagine, freezing of gait is associated with disability, higher UPDRS score, the MDS UPDRS scores. That's an objective scoring system that we use to assess the severity of patients' clinical signs and symptoms, and it correlates with much higher scores. And as I mentioned, that it is significantly associated with their quality of life. Some of the other gait abnormalities that we see in the clinic is, one is called festination, which is an involuntary acceleration with shortening of step length. And you'll see, actually, contrary to what you would think, in slowing of gait, the patients cannot control that and they start walking faster, but with very short steps, or may some patients do it in a tiptoe fashion, and that invariably can lead to falls as well. And it's a huge predictor for falls as well. So, as again, postural instability, en bloc turning, those are all some of the gait abnormalities that we see as folks advance in the course of their Parkinson's disease. Another big issue that can contribute to gait abnormalities and to all of these problems of gait, with freezing, shuffling, en bloc turning, festination, things like that, is motor fluctuation and dyskinesias. So, motor fluctuations is, again, when early on in the course of the disease, patients' brains are making a good bit of endogenous dopamine, and they are less reliant on exogenous medications, or levodopa or other Parkinson's medications, because they still have a good bit of endogenous dopamine to fall back on. So in the clinics, we see early on in the course of the disease, patients can go in between doses with a much longer duration. Sometimes patients even may forget to take their dose, when they're at work, etc., and they don't feel any um, change. They don't feel what we call wearing off, or their off symptoms of maybe tremor, or um, gait disturbance, or stiffness, rigidity, bradykinesia show up. But as the disease advances, they're more dependent and reliant on their medications, and the benefit from the medication may not entirely last up through the next dose, and they have what's called wearing off, and it can be both predictable and unpredictable, and that makes it even more challenging for the patient, and impacts their quality of life, because if they can predict it, like, say, my dose is going to wear off an hour before, then we can adjust medications, reduce the time in between the dosing, increase the frequency of the doses, add other medications, whatnot. But if they have unpredictable off. That makes it a little bit challenging, but there are some rescue medications now available that the patients can use and quickly turn on, as in be able to move again and mitigate their symptoms of Parkinson's. And these are basically a levodopa inhaler. Dyskinesias are when the levels of levodopa go up too high. They experience significant involuntary movements, and I'll show you a video later on. And that can also affect their balance. They may not have shuffling or freezing at that time, but because dyskinesias are involuntary movements that are difficult to control, it can affect their balance. I'm not going to spend time on this slide. As Dr. Peterson talked about, both dopaminergic and non-dopaminergic mechanisms are at play in causing gait dysfunction. One, I will just highlight the peduncular pontine nucleus, which is an area of interest where cholinergic deficits have been found. And because so there was a trial done with rivastigmine, which is a cholinesterase inhibitor, to see if it would improve gait dysfunction. And it was a phase 2 study. It did show some improvement in gait stability and improvement in gait metrics as stride length and stride length, etc., and reduced the number of falls. However, it did not show any improvement in freezing of gait. A larger study needed to be done to corroborate those results. If you're interested, this was published almost a decade ago now in Lancet Neurology, if anybody's interested in pursuing that. Basically, we understand gait dysfunction to be now mostly like it's a network dysfunction. So as Dr. Peterson pointed out, that there's a lot of signaling going on back and forth between the cortical basal ganglia, brainstem, and cerebellar areas. So any disruption, impairment in that network can cause problems. Also, based on our research in the brain bank, where we follow patients serially, annually through life and clinically assess them, and then when they pass on, the neuropathologist studies their brain to correlate their symptoms in life to what changes are seen on histopathology in the patient's brain. There is now a lot of evidence that supports that white matter changes, regional atrophy, and other comorbid conditions, changes that are seen in Alzheimer's disease, etc., coexist in patients with Parkinson's disease. So all of these co-pathologies can also make patient symptoms worse, including gait severity. Obviously, impaired cognitive function affects gait dysfunction just like everything else would, especially if they are not realizing their limitations, engaged in multitasking, etc. That can really make their gait worse and make them more prone to falls. Biomechanical factors, as this is a disease of the elderly, reduced hip, knee function, arthritic changes, etc., can cause and exacerbate gait dysfunction as well. As you can understand, this can have a profound effect on the patient's quality of life. Freezing of gait is the strongest motor predictor of reduced health-related quality of life outcomes. It can lead to, a loss of independent function, fear of falling, anxiety, and lead to social withdrawal. There's a lot of data that shows that up to 70% of patients with Parkinson's will have a fall on a year-to-year basis, and 39% of them fall recurrently. Again, recurrent falls is associated with a median survival of 6 years. So as you can see, it significantly has a very significant impact on mortality and morbidity. We already talked about increased risk of hospitalizations, etc. So I'm just going to move on to the clinical part of the talk. So thankfully for patients with Parkinson's disease, we do have a lot of tools in our toolbox. Although gait dysfunction, balance problems, especially in the on state, as in when the medications are working, still remains a huge unmet need. So this is basically, this slide shows the landscape of all the different medications that are available. The ones that are highlighted in red are the newer ones that have been available in the last uh, 2 to 3 years, and some of them that are coming soon. Most of these work on the dopamine system. I just wanted to highlight this one particular category, the estradifylline or the adenosine 2A receptor antagonists, because they don't work through the through increasing dopamine levels. They're basically involved in reducing the overactive indirect pathway in the basal ganglia signaling, and thereby improving motor function. So currently in this day and age, levodopa remains the most potent, best drug to treat patients with Parkinson's disease. It improves bradykinesia, gait parameters in mid-stage, advanced stage disease. Although we run into issues where, as the disease advances, the patients may experience what are called levodopa-resistant symptoms. So worsening of balance and gait dysfunction, especially in the on state, when the levodopa is still controlling the bradykinesia, may still be reducing the tremor and still reduce the stiffness. If patients have gait dysfunction at that time, then that makes it very challenging. Further increasing the dose of levodopa may not be the answer and may not mitigate gait and balance problems. Having said that, if the patients are having wearing off, then obviously, changing the regimen of their levodopa or adding other dopaminergic drugs or other medications such as MAOI inhibitors or COMT, catecholamine, O-methyltransferase inhibitors, all of which indirectly raise the levels of dopamine in the brain, can be helpful. In Parkinson's disease, there are a few different phenotypes. So the patients with the tremor predominant Parkinson's disease, where early on and for initial several years, tremor was the predominant disease, they tend to do better overall as compared to the PIGD subtype, which is the postural instability and gait dysfunction subtype, or the akinetic rigid subtype, who don't have a tremor, but postural disturbances, stiffness, rigidity were the presenting symptoms. They tend to have more earlier and severe gait dysfunction. Obviously, factors like we talked about, cognitive dysfunction, age will have an effect, and comorbid conditions. So neuropathy, idiopathic, or in diabetics, vascular disease. So who have metabolic syndrome, so hypertension, diabetes, cholesterol problems, that affects your blood vessels, especially in the brain, and can cause, what's called microvascular ischemic disease, if not large strokes. So all of that can contribute to the worsening outcomes in Parkinson's disease. I just wanted to show this slide to highlight what I was earlier talking about. In early stage disease, there's a longer duration of benefit with levodopa and lower incidence of dyskinesias. But as the patient progresses, and they take more medication, there is a narrower window of good on time where the patients don't have dyskinesias and are not having their Parkinson's symptoms. And as you can see, in advanced diseases, advanced stage of the disease, that window gets even smaller, where the patients oscillate between having what's called troublesome or bothersome dyskinesias with very little good on time, where actually they're doing well in terms of not having dyskinesias, but not having their Parkinson's symptoms as well. And then they drop, as the levodopa levels drop down, they turn off and have their symptoms of Parkinson's come back again. I know Dr. Peterson showed a video. This is just another video to show the effect of how good your potential is initially off state, and having, being on, as you can see there, what time initiating. So he's frozen and has very small steps. As again, that unblocked turning, where it takes multiple steps to turn, has a very hunched posture as well. And this is after levodopa, when the medic came into significantly, much more. And we do this type of an assessment to see, to test for levodopa responsiveness before some of the more aggressive interventions. Now, obviously, initially in the earlier stages of the disease, patients are given levodopa by mouth, but as it advances, now we have the option of giving them through different means. So in moderate to advanced stage disease, Duopa infusion therapy is FDA approved, where there's a PEG J tube that goes directly into the intestine, and through a pump, levodopa carbidopa intestinal gel is continuously delivered to the intestine, where it would get absorbed. So this beats the oral medication, where it has to travel through the entire GI tract. And as many of you may know, there is GI dysmotility, so there's slowing. So even though the patient may take the oral medication, it may not get to the site of absorption in time, and the patient will experience off symptoms. So this helps mitigate that. More recently, in the last couple of years, FDA has approved Vyalev, which is, again, a form of levodopa carbidopa therapy, but through a subcutaneous infusion. So this involves a pump and a small needle, which will continuously deliver levodopa through the skin and be absorbed to, again, reduce the off time, and it increases on time without troublesome dyskinesias, things that we would run into with oral levodopa therapy. Another drug that has been recently approved for another infusion therapy that has been recently approved is apomorphine, which is a dopamine agonist. So it is a drug that would stimulate the dopamine receptors in the brain, and thereby bring about its effect. Again, it's an option for advanced PD, and it helps with smoother control of the motor fluctuations. As I mentioned, it would bypass the GI tract. And, again, studies showed a significant benefit. So there was less off time by about 2.6 hours as compared to, placebo. And it increased good on time, where patients were not dyskinetic and were able to not also have their Parkinson's symptoms by about 3 hours during their waking day. Another treatment modality that is commonly used in a moderate to advanced stage Parkinson's disease patient is deep brain stimulation. STN, or subthalamic nucleus, and the globus pallidus interna are the two most common targets for a deep brain stimulation. What it involves is basically implanting electrodes in the brain that is connected by a wire to a pacemaker type device that is implanted in the patient's chest. Pre-surgical levodopa response helps with knowing what the patient is going to do, what things are going to improve post-surgery. There has also been a a growing interest in putting DBS electrodes in the PPN, and especially for gait dysfunction. And there have been some small case series reported where it helped. Also, using low frequency or targeting the ventral part of the STN has shown to be more beneficial in terms of gait dysfunction. And now there is what's called adaptive DBS, where there is technology where the DBS can sense the what's called the local field potentials and modulate the stimulation parameters based on the level of the activities. So this is a video that shows, so this is in off when the patient's DBS is being turned off. You can see having a difficult time turning off, but the same thing posture, very small steps. And this is again in the on state when the DBS is on, you can see much larger steps, more fluid movements, etc. This is a video just to show how much impact the dyskinesias can have on a patient's quality of life. So here the patient is on, he has taken his medications, but as the medication kicks in and the levels go really high, they have these extra movements that are called dyskinesias. You can see it in the head and neck. Doesn't have a lot of bradykinesia on the fingertips, but you can see how dyskinesias can be disruptive to gait and balance because they have these uncontrollable movements. And DBS will also help with the dyskinesias. In the interest of time, I'm just going to fast forward through the video. Here we're just trying to get him up, but because he's so dyskinetic, he's not able to, maintain his center of gravity, has a hard time standing up unassisted. With DBS, we can take away the dyskinesias, we can reduce the amount of medications. His balance is not perfect. And unfortunately, in the on state, when patients have balance problems, not much can be done about that except physical therapy. That remains a very important pillar of gait management. Gait, balance, functional training improve with physical therapy, aquatic therapy, dance, resistance exercise, and obviously participating in programs like Rock Steady Boxing, which involves exercise, but also fun activities, and engaging in a group setting that is social therapy, if you will. So that has positive impacts on cognition, mood, and improves quality of life. This is my last slide. So future directions now with all the advances in technology, and my colleagues at ASU are, also leading the field with some of this research with wearable sensors and freezing of gait detection. It would be very nice if patients could get some kind of a warning or some kind of an indication that they are going to freeze before it happens so that they could take steps to mitigate that, like maybe stop and then take a big step. Visual cues, like Dr. Peterson showed, there are walkers and canes that have a laser beam that comes out that provides a visual cue that can help the patient with breaking their freeze as they can stop, as they can step over the laser beam. Tele-rehabilitation and app-based cueing platforms. And again, as I talked about, some of the newer advances in deep brain stimulation will also hopefully help mitigate some of this gait dysfunction. And lastly, the holy grail is to find some disease-modifying therapy with which we can slow or stop the progression of the disease. And that would help with not getting to an advanced stage of Parkinson's disease. That would be awesome. So these are the key take-home messages. Gait disturbance is a big contributor to disability in advanced Parkinson's disease. It's a multifactorial pathophysiology. We have a lot of treatment tools at our disposal, but it still remains a huge unmet need. And hopefully some of the emerging technologies and therapies will help solve this huge problem. Thank you for your attention. I'm going to stop sharing my screen.
Thank you, Dr. Mehta. Everyone, if you haven't already done so, make sure you register your attendance in the self-check-in link in the chat so we have accurate attendance. So I'm going to go to some questions real quick for the time remaining before we head out. So there's one question that sort of indicates, how should an individualized care plan be structured for a patient with Parkinson's disease who has a history of recurrent falls?
So I'll take that one, Dr. Peterson. So that's that's a great question, and I don't think I have enough time to answer that. But I think an individualized. So, I think I'll preface this that Parkinson's disease, we say this very often when we give talks, but when you've seen one patient with Parkinson's disease, you've seen one patient with Parkinson's disease, because everybody symptoms are different, even though they fall broadly in that, a category of bradykinesia and rigidity and things like that. But the constellation of signs and symptoms is very different. So you're absolutely right. It has to be individualized. What medications they tolerate. The mainstay of medications is levodopa. Now, a lot of times patients may have difficulty tolerating levodopa, and we've gone to deep brain stimulation in those patients. So, it has to be individualized, but these are the main areas of therapy that we encompass. So, as we talked about physical therapy, occupational therapy, speech therapy, they form a very important component of a patient's treatment plan. Medications, they've already been on it. They continue to be on it. Their regimen may have to be amended by increasing the dose or increasing the frequency of the doses. And if possible, then some of the advanced therapies that I talked about, either subcutaneous infusions or DBS or things like that, may have to be implemented as well. So, every patient, is different. So it has to be individualized.
Thank you. Thank you. We go to the next question. Try to get through as many as we can. Our gait, maybe if I'm reading this, our gait issues, I'm assuming PD gait issues related to various forms of dementia caused by the same pathophysiology.
Yeah, if you want, I can comment on this. And the short answer is yes, in that some of the regions of the brain that are influenced by dementia or Alzheimer's disease, there is overlap in some of those brain regions and the brain regions that can contribute to gait. At the same time, a lot of the difficulties and by the way, people with Alzheimer's and dementia do have altered gait patterns. However, a lot of those gait patterns are kind of, I guess, circumstantial in nature, in the sense that, when you have these changes in attentional control or executive function, you might observe things like poor dual task walking. You might observe things like increased risk taking during mobility, right? So as you're walking through, you might choose to walk across a street that may be more dangerous than would be ultimately a good idea, right? So you do see changes in walking in people with Alzheimer's and dementia. And I think it is a mix of kind of direct cause, that is, the brain regions affected in let's say, case of dementia can influence gait, and also indirect causes, such that changes in cognition can then result in altered ability to safely move through the community. While I'm here, I was just noticing some of the other questions. One other question I noticed by the same person from Janet Welsh was about uniform flooring as a way to minimize freezing through doors. And I would say absolutely. I think in general, there are a lot of circumstances in which a really thorough, and maybe Dr. Mehta can comment on this too, but a really thorough look at a person's home environment to reduce different triggers of fall risk or freezing risk could be really beneficial. So I know we speak a lot about the neurophysiological changes that can increase fall risk, right? So changes in the step length and changes in the brain function and so on. But adapting a person's environment to be safer and less likely to elicit freezing and less likely to cause a trip. So, for example, even just like rugs with frayed edges, let's say, non-stick or non-slip flooring in the bathroom and so on. All of those can be really important ways to improve the safety of mobility inside a person's home, which is where falls commonly occur in those folks.
Thank you. I'm gonna try to get this. I'm trying to combine these next two questions a little bit. So, what challenges and opportunities are associated with the health and well-being of PD caregivers, for instance, like in sense of like managing their medication, managing their on and off fluctuations?
Can you just repeat the question? I'm sorry, just one.
Yeah, so one's like so I'm trying to combine two questions in one. One, what are the challenges and opportunities associated with health and well-being of PD caregivers? And in those PD caregivers, how can they manage these on and off fluctuations that help increase with fall risk?
Yeah, that's a great question, and I wish I had like this perfect answer or the solution for this problem. But we know that there's a lot of stress associated with being a caregiver for somebody with Parkinson's disease. And as Dr. Peterson said, as there is the cognitive decline associated with the disease, the patients don't realize that they are, if they do this particular, stand up too quickly and just take off or not use their walker and things like that, that they're much more prone to falling and things like that. So, especially in our clinics, I've seen where the significant other or their partner, you know, continuously remind the patient that, okay, you have to use the walker, or if they're experiencing some degree of cognitive decline, maybe take over the medication management at that point, because the patients may not be taking their medication correctly, and that may be also impairing or causing more falls and things like that by increasing the off time. So taking some things off the patient's plate and unfortunately putting them on their own, sometimes can help.
And then what are some preventative strategies that could be implemented to prevent Parkinson's disease?
So we don't. So right now there is a lot of research going on to try to figure that out. So we now have biomarkers with which we can detect what's called prodromal PD. So prodromal is where they have not yet met diagnostic criteria for a clinical diagnosis of Parkinson's disease, but are showing some of the risk factors like REM behavior sleep disorder, or reduced sense of smell, or hyposmia, constipation, depression. Now there are some biomarkers where we can do by through skin biopsy or CSF studies, through seed amplification assays, detect this, or the DAT scan can show reduced presynaptic dopaminergic deficit, even though the patients may not have manifested the signs and symptoms yet. You see these changes. So, now that we can enrich this cohort or this population, we can try to study some of the interventions in that to see if we can delay or slow the progression or of disease. One thing that I will definitely pitch and is exercise. So there is a lot of data that shows that in patients who are diagnosed with Parkinson's, if they exercise cardio, stretching, Tai Chi for balance, over a long period of time, they tend to do much better as compared to their counterparts who are much more sedentary, and don't exercise.
You that's sort of question I got. It's like, how does pharmacological influence the fall risk, and how can nurses and other healthcare workers assist with managing those fluctuations?
Dr. Ofori, you're breaking up. I couldn't hear the question. I apologize.
Uh, how does pharmacological management influence fall risk? And then how can nurses help manage those fluctuations?
Right. So our nurses obviously play a very, very important role in helping take care of our Parkinson's patients. So, uh, the pharmacological issues can play a big role in, helping prevent falls, as well as may play a role in causing some of them, because a lot of these medications have side effects, right? So, like Dr. Peterson talked about the important role of cognition. Now, some of the dopamine agonists can worsen cognition, especially in the advanced stages of disease. So, we typically tend to avoid people um, putting people on them, especially if they're having showing signs of cognitive decline or early signs of dementia and things like that. So that can be a big factor. Some of the dopamine agonists, high doses of levodopa, other meds can drop the blood pressure, can cause orthostatic hypotension. So, that is another reason why people fall. Like when they first stand up from seated position. And again, if they are not aware of this, that they have to stand slowly or hold on to something and stay there in place for a few seconds for their blood pressure to stabilize, they may just quickly stand up and take off. And because of orthostasis, their blood pressure drops, they may feel dizzy, lightheaded, and that can lead to falls. So, it's a double, medications are always a double-edged sword, right? Our nurses a lot of times help identify these issues, when they talk to the patients, when they call, they'll ask them, like, did you feel dizzy? Did you feel lightheaded? Look at the doses and things like that with medications. And
you. Those are great responses to the questions. And again, thank everybody for joining us today. If you've not done so already, please register your attendance like I indicated before. We encourage you to follow the College of Health Solutions on social media, where you'll learn about any opportunities like the ones you heard today. So if you enjoyed this, there's more that are coming from the College of Health Solutions. Our next health talk will continue on March 19th, and details and registration will be available at the ASU Health Talks website. And thank you again, and everyone have a great rest of your day.